Yes, sir. You are.
Yes. Can I start?
No, sir. I will. Abhi live start hoga. I will give the introduction and then I'll request you to address. Then please start. I will
Okay.
request you once we go live. Okay. Anyways, good evening, everybody. I welcome all the audience once again in another edition of our knowledge exchange series on infectious diseases control, supported by Mylan Pharmaceuticals. And as you all know that, and many of all of the new audience, I would like to tell you that we are working on this series of creating awareness, exchange of knowledge and ideas and best practices in the infectious disease control in India. And as we all know that currently COVID-19 is the whole world is dealing with. And at the same time, we have other infectious diseases also prevailing in India, like tuberculosis, hepatitis. So while the country is struggling with COVID, how the whole ecosystem, how our public health ecosystem needs to be prepared to fight with all these infectious diseases to control them. So in this panel today, we have eminent panel today to discuss on this very important burning issue today in the country. I welcome them once here in this panel, and I introduce them to all of you. Welcome, Dr. K. Madan Gopal. He is Senior Consultant for Health in Niti Aayog. Welcome, Dr. Saab.
Good afternoon.
And I also welcome Shri Naresh Hasija, who is Associate Vice President of Mylan Pharmaceuticals Private Limited. Most welcome, Mr. Naresh Hasija. And I also welcome Dr. Pachaul Almal Samama, State Nodal
Hello.
Officer for COVID Task Force and IDSP, Health and Family Welfare Department. Welcome, Dr. Saab.
Thank you.
And in some time, Dr. C.N. Manjunath will join us, who is a Professor of Cardiology and Director of Shri Jaydev Institute of Cardiovascular Science and Research. And he will be joining us in a short while. So to start this discussion, as we all know that Niti Aayog is the body works on policy framing in the country. And today, in front of all the policy makers, all the administrators, one of the major problem is COVID-19, and which is a very big part of infectious diseases. So I would like to ask Dr. K. Madan Gopal to kindly present his views, his ideas on this very important issue. So Dr. K. Madan Gopal.
I will be just. Hello, I'm audible to everybody. Yes.
You're
Hello.
audible, but your camera is stuck.
I don't know because you told me not to do anything. That's why. To camera, I don't know whether it is. So what to do? Shall I start?
Yes, please.
Okay, I will
Please
be doing that. So I won't be going into the details of the agent because in epidemiology we talk about the agent, host, and environment. But straight away coming to
Yes.
the point that I will be talking about a few of the host factors, few of the transmission dynamics based on the insights which we are gathering as the infection is maturing, and we are getting insights, and our insights are also maturing as the day progresses. So I would be just focusing on that aspects and what strategies which we are adopting and how the strategies will go forward in containing the spread. I would be just focusing on that, not on the details, nitty-gritty, and other things. So I'm thankful to
That
my
will be great.
colleague who has helped me with this presentation. So he's Colonel K. Venkat Narayan. He's also working with us closely with the COVID response. I would be just the key interpretations for the policy decisions are mentioned in the yellow boxes on the respective slides. I would be just straight away going because agent, everybody knows how the infection comes, that everybody knows, but I would be straight away going to the host factors. What are the host factors? That what happens to the host after the infection comes? This is a response which you can see that the incubation period ranges from 6 to 22 to 21 days, but the peak viral load days are 0 to 5 years, where the person is very, very infectious. So that's the time where a lot of interventions, because why I am showing this slide, because this will give an insight that where we have to start. One of the major challenges for control of any infectious disease is breaking the chain of transmission, targeting the source of infection and the reservoir. So if we don't know that the source we know, the reservoir we know, that's very difficult. But now the transmission usually happening about man-to-man transmission, human-to-human transmission. And we should know that which are the peak days where the infection can happen. The infectious period is before the onset of symptoms to day 10. That is, the symptoms are usually visible after 3 to 4 days or 0 day if you call onset of symptoms. After the onset of symptom, the person is getting tested, but unfortunately, in our country, we are only counting the day when the person is positive as a day one of the infection. That's another thing. But all having said all this thing, if you do a culture after 9 days, it's very difficult to find. Though the irony viral shedding happens, but after 9 days, you are not able to detect the virus. That's why the whole strategy is that after 9 days, initially we were doing repeat RT-PCR for discharging the patient. As we matured and as we got information, then the whole of the discharge policy changed, and now we can discharge the patient after 9 days if he doesn't have any symptoms, if he doesn't take any medications for the 2 days. This how this kind of graphs can have implications on the policy decisions. You can appreciate that because uh, this has implied the testing as well as implied the discharge policies. This is the viral load dynamics in the period of infectivity. We have been talking about the infectivity of the people. In the x-axis, you will find that quantiles of distribution number of positive cases. These are all from the studies which the references are given below. If you look at that, 70% of the asymptomatics, the secondary attack rate is more or less minimal. As the percentile of the people who are having infection, you will find that 70% of the cases doesn't infect others. If when we prospectively follow that thing, there is no linear correlation between delay in the timing of diagnosis and generation of large number of cases. This proves the above 2 points that the secondary attack rates from asymptomatics as well as the symptomatic cases. When we follow up, there is no linear correlation between delay and timing. People will say that the person has come late, but there is no correlation as per the studies which we have come up with. Then what are the factors which influence the transmission dynamics? These are the contact pattern, that is proximity to the index case, time of contact, duration of exposure, contact frequency, activity, the environment, indoor ventilation, long-term facilities, then the host factors, the agent, infectious, and the economic factors. These are the factors which influence the transmission dynamics. But what we have observed that for each case, there has to be some spreading infection, spreading event. Initially, we were doing this thing. As we go on with the next presentation, we'll appreciate the response which we have taken in the country. It has a dispersion, over dispersion effect. It tends to spread in clusters. That's why we have been saying that till now we are having clusters, because if you do a retrospective or a prospective contact tracing, you will understand the concept of cluster. So what is this cluster? Cluster is a event which is characterized by the super spreading event. Initially, you might have heard in the Korean experience as well as in the Agra experience that how the cluster of cases has spread. And the cluster is characterized by prolonged contact, a highly infectious person, poor ventilation, overcrowding, and some of the unknown factors. Apart from that, we cannot explain RO, that is R naught, which people have been talking, but need to factor in the dispersion factor. So what is, due to high dispersion, COVID infection typically does not fit into any particular mathematical model. We have seen many mathematical models, but because of this high dispersion, we could not, it typically has not fit into any particular mathematical model. So what is this K factor? K, it is a pictorial representation of this. For 1918 influenza, the K factor was around 1, which meant that perhaps 70% of the infected cases did not transmit the disease. For the SARS and the MERS, the COVID factor is as low as zero point 0.1. This means that as many as 70% of the infected cases do not transmit the virus. Conversely, it means that the disease would spread only by few as super spreading events. So this is a very important aspect for the containment of the other measures. If you look at the insights of the transmission dynamics, it's the highest probability of transmission occurs within the case contact pairs of a similar age. Like there's a strongest correlation for children 0 to 14 years of age and the older age group of 65 years, because the children they tend to play together, whereas the older people they tend to isolate themselves and they remain separate with each other. The greater proportion of the test positive contacts within the most age group were exposed to 20 to 44 years. This is a very crucial because they are productive, they are going out, and they bring an infection. When we did the analysis of the data which was made available to us by NCDC, we found that in people less than 50 years of age, the infection is 78% to 80%. But if you look at the mortality data which was made available to us, we found that the 80% of the deaths which were reported happened in the age group of 50 years of age. That's why this greatest proportion of the people, that is 20 to 24 years age, we have to see that how we target this group so that the infection spread and other things are contained. In a committee having a normal non-pharmaceutical practices, sporadic cases account only for 14% of the cases. Rest of the cases should be identified as cluster. That's why we were focusing too much on the cluster containment strategies. So this is the overview of the strategies which we are having. There are two strategies. One is retrospective strategy and the other is a prospective strategy. What is this retrospective strategy? Retrospective strategy is usually followed by countries which are having good practices of non-pharmaceutical interventions like mask wearing, social distancing, and soon social distancing, and soon after the onset, which has happened in Japan and other countries. And it predominantly focuses on cluster identification of super spreader of the cluster containment. And if the cluster is not identifiable, it will mean that sporadic cases are on rise. It will follow into lockdown and containment strategies. This we were doing before the lockdown, and initially we have practiced this thing, and it was a very successful thing which we have this. What is this prospective strategy means? We are ramping up the testing, identification of the contacts, then the identification of the positive, contact testing, then treatment isolation. Apart from selective lockdowns, intermittent relaxation, maintaining non-pharmaceutical intervention by the public, and searching for an ideal vaccination. Apart from the getting epidemiological insights. Mitigation as a strategy which focuses only on reduction of deaths and emphasize is not followed as a principle. This is just a graphical representation. You see a positive case, cluster containment because one super spreader is there, and if you contain that super spreader in this. Whereas in a prospective thing, positive case, you identify the contacts of the positive case, then early contact tracing, isolation, and care of the contacts. Both appears to be similar, but retrospective strategy is more intensive and more effective. So what has been the Indian pandemic characteristic? It is a persistent epidemic heterogeneous profile because every state is in a different phase of epidemic in the early deaths are occurring. Maximum number of deaths are happening within 5 days of diagnosis. We have ramped up the testing with the RT-PCR and the rapid antigen test. Despite a higher number of deaths and cases, high testing rates compared to the countries we are having higher deaths, higher cases, despite high testing rates as compared to countries like Japan and Sri Lanka. The epidemic is not always explained by mathematical model. This means that high dispersion factor is also playing in this epidemic. So India has been predominantly prospective strategy. The strategy, if you look at the graph, till June, you see that a plateau because that was the time required because we were not aware about the non-pharmaceutical interventions. That's why lockdown was supposed to be introduced at that time. We have not ramped up we're not doing the testing. We didn't have the capacity to test at that time. Apart from that, the health infrastructure and the human resources for health knowledge needs to be augmented during that time, and we have utilized that time effectively. So what we did during that time, we have ramped up the testing, we have trained the people for case identification, early contact tracing, isolation of contact, and care of the testing. As we matured, though the number of cases have improved, but the mortality has also come down. We have ramped up testing. Now we have tested around 1.5 million tests per day. This happened on 25th of September. And today we are having 75 lakh cases and a daily case which peaked around 97,000 on 12th of September, around in the mid of September. Now it is exactly half of that, that is 46,000. Deaths are also reducing. The testing is more or less in the range of 1 million. And in fact, on absolute number, we are the largest number of, we are doing the largest number of tests across the world. Sometimes the US supersedes that, but on an average, we are doing the largest number of tests in the world. Then what we have been done so far, we have done a containment strategy. We are having lockdowns to prepare ourselves, early case detection, contact tracing, isolation measures. We are having a committed governance, formation of coordinated task force. Previously, it was 12 coordinated task force. Now they have been merged, and now we are having 6 task force. We have mobilized the healthcare worker. We have ramped up the infrastructure, equipment, oxygen. We have encouraged public participation, SOPs for treatment, contact tracing, support to public by monetary compensation. So this has all happened. Apart from that, we are now having the suppression also. We are lifting the phase down in a lockdown manner. We are phase wise lifting the lockdown. Zoning of district has happened. Federal situation based decision. You might have seen that the central teams are sending to some of the states so based on the situation. And ramped up rapid screening, work based opening SOPs are there. Then guaranteed public service delivery. Even apart from the COVID services, now we are opening the hospital services. If this is the response has paid so far, if you look at the example of Tamil Nadu and this, if you look at the R naught, that is the number of secondary infection each infected risk is likely to generate, it has declined from 1.7 to 4.3 Tamil Nadu, from 1.7 to 4.3 and 1.4 to 4, from 4.3 to 1.4 and 4.3 to 1.7 in this during this. Post lockdown, the has been the transmission, that is the reproduction rate has been percentage into the lockdown. Thus has indirect effect in reducing the transmission. Yes. Then the way forward is we have to have a balance of this. The retrospective strategy, we have to restart it because initially we were doing it with a very, very good result. With the as we have ramped up the testing, other things, somewhere this has taken a very, it has slowed down a little bit. So we have to see see that how the possible benefit. We have to have a mixture of retrospective strategy as well as the prospective strategy, so that we can contain the spread, we can reduce the mortality, and we can because festival times and winter is settling too. This strategy would be very useful. Now, what is happening across the country in a few of the states, it would be happening that the person is taking positive and only his contacts are thing. We are not tracing backwards and identifying the cluster with the super spreading event, how the infection is spreading. Then the other is this is the prospective strategy. We have to maintain the ramped up testing. We are doing on an average more than 10 lakh tests per day. We have to strengthen our contact tracing, isolation, surveillance measure. We have to ensure the public use of non-pharmaceutical and engage community, improve quality of the test, that is test of test, quality of care, quality of surveillance mechanism with regular checks and balances. Integrate data and encourage transparency in reporting. This we have to do it. And apart from that, destigmatize the disease, which is more or less we have been able to at least allay the fear of the people about the disease now. Now it's a manageable kind of infection. The use of technology to unlock and manage and continue research for vaccine. Then, as a way forward, we have to combine both the things. We have to engage with the NGO, CGO to track clusters, need separate working group. We have to do a cluster management, which would be ideal for the rural India. We have to see that how we introduce importance of this contact tracing and other things in the workplace also. And we have to make people more aware about practicing non-pharmaceutical intervention. This can become a primary strategy. We have to continue with the current system with augmented effort and try to incorporate retrospective strategy wherever feasible. This this is all. That means what will be the next scale. Initially, the public was not aware about NPIs and culture. Health system was not prepared. New virus, poor understanding, heterogeneous spread. That was the thing which we did. Then now, at least many people are aware about the non-pharmaceutical imperative. The health system is prepared. New virus, better understanding. As we are maturing into the epidemic, now we are better prepared than we were prepared during the months of February, March. This is all from my side. Thank you very much.
Thank, thank you so much, K. Madan Gopal, from Niti Aayog, Senior Consultant for Health. And we all know that you are one of the major pillars in strategizing this COVID-19 management in the country. And it's great to know from you that how this country is, the government is dealing with COVID-19. Thank you so much, Dr. K. Madan Gopal. I'll come back to you later in the discussion. And I would just like to introduce here that Dr. C.N. Manjunath has joined us. He is Professor of Cardiology and Director at Sri Jayadeva Institute of Cardiovascular Science and Research Center. Dr. C. Manjunath, most welcome. You are welcome in this discussion.
Yeah. So first of all, I thank you very much for arranging this platform to discuss about this COVID pandemic and also how we are progressing positively in this direction. And I just heard Dr. Madan Gopal, briefed A to Z how government is responding to this. It's a very nice presentation, and also see we have, as Dr. Madan Gopal was telling, we have traveled nearly 8 months with this COVID-19 virus, and we have learned lessons, and we are still learning a lot of lessons, and disease is better understood as we move on. So one thing definitely for the last 8 to 10 days, we can see some downward trend, decline in the number of new cases, even more discharges and less number of active cases, more discharges, and also the fatality rate is coming down. The one most important thing is we are, of course, even WHO right from the beginning is telling only you have to do 3 things, that is test, test, and test. So we have to do a lot of tests. And in Karnataka alone, we are doing daily about 1 lakh tests in the state of Karnataka. And it's almost like 65 to 70% RT-PCR and about 30% rapid antigen. I think even this rapid antigen has really reduced the burden on RT-PCR system. We agree that the sensitivity is around 50 to 60%, but still it has tremendously reduced the burden on RT-PCR, and we are doing targeting testing. Of course, all over the country, the same pattern is followed, where people who are in more public contact, those who are in healthcare workers, those who are maybe the marketplaces, all those, then those delivery boys, housekeeping, Pora Karmikas, and so these are the people, and even the vegetable vendors or footpath vendors. So what I had seen here is, in fact, the positivity rate at this point of time in our state is around, on an average, it's around 12%, but it has started dropping actually. So most important thing, there should not be any complacency on this. When you are, when the number of cases are started dropping, this is the time one has to strictly follow the same precautions what we are following, maybe with respect to physical distancing or maybe even using mask. See, in our country, what is happening? Yes, most of the people are, of course, I am talking, I have taken out the mask. They are wearing mask, and they exactly take out the mask while talking, coughing, and sneezing. So whole purpose is defeated. So anyway, another important thing that is what has happened here, the government of India and all the respective state governments have strengthened their infrastructure, particularly in urban and semi-urban places, because this has given a tremendous scope and opportunity for all the public health sector to really reinforce their basic healthcare services. Because but for this, probably only some good medical colleges or good government hospitals would have at this facility. Today you go to any remote corner of the country, at least in our state, must be in the same, must be same even in other states. Even a taluka hospital, a primary health center, has some oxygen beds, has some ventilators. So these are some of the brighter side of this pandemic. And also the liquid oxygen plants are in place in many places, and even the RT-PCR labs. For in our state, for example, in the month of March, we had only 8 testing labs, 8 tests. Today we have 160. In the state of Karnataka, we have 160 labs. That's what it has happened. And another good thing that has happened is, I think a lot of indigenous production has come through. So earlier, garment, of course, Karnataka has plenty, thousands and thousands of garment factories. Now they've all, started stitching all the masks and PPE. So this is what sometimes the scarcity has given, the problem has become an opportunity, I should say, in form of producing more PPE kits, more masks and all. Another interesting thing, as initially we thought this disease is basically a primary respiratory illness. Then as we moved on, we have understood that it is also a thrombotic disease. And at least in my opinion, these 4 drugs the combination of these 4 drugs have made a significant difference with respect to recovery time, and also has reduced the hospital stay. That is, one is steroids, and second is remdesivir, and third is heparin. These and also, of course, oxygen also you should take it as a drug. And these have, so most important here, the home isolation is also an important thing. As a result, we are giving more beds to the needy patients. And another important thing that has been, technology has been used to track these home isolation patients, and also the results of testing have been pushed through the bulk messaging and all. So I think now there is a sort of a feeling among the treating physicians that yes, even if they have this infection, most of them will recover, because 90% are getting cured either on their own or with very simple treatment. Around 8% require oxygen in our study. And another important thing, what we are looking at, only we are talking about COVID and COVID and COVID, and a lot of non-COVID patients are suffering today. Non-COVID, in fact, we have done a mortality analysis. For every 100 deaths happening in our state, nearly 20% are cardiac deaths, and another is kidney failure. So what is being talked about, what is being projected is all about COVID deaths. So non-COVID care also should improve parallelly. This is extremely important. Otherwise, many smaller hospitals have been closed, smaller clinics have been closed. I think this is one area we have to really start supporting these clinics. Maybe government also might consider. Another thing, what I am, of course, may not be in this particular instance, as far as in a public sector, in a government sector, Government of India is opening a lot of medical colleges, even government, the aims like institutions. What I feel is they only fund the building and the equipments. They should also fund the manpower also. Then only they will start working. Many times what has happened, fantastic buildings, excellent equipment, but there is no manpower. So our focus should also move from the construction to creation. So construction to creation, so that's what I keep telling. If you are approving a project, maybe an hospital, maybe a district hospital, or maybe a medical college hospital, either under the state or under the Government of India, at the time of giving an approval for the project, kindly consider and give approval for the manpower also. If you are not giving approval for the manpower, don't give approval for the building. So otherwise, I think many have become a ghost buildings, and this is where probably India has to relook. Otherwise, healthcare system is going to suffer. For the one, in fact, I will tell you, to create a post, it is because the enthusiasm that is there for construction is not there for creation of post and all. This is how we should go about. And festival is around the corner, very very important. So as festival, so this is the time. There could be a surge, there could be a second wave, or maybe extension of the first wave. So because COVID and crowd go together. So whenever there is a crowd, always because virus doesn't move actually, it's the people who are moving the virus. So the COVID and the crowd together, they should avoid this. Very very important is now the festivals are coming up. Unfortunately, Government of India, the Election Commission has declared elections. In many by-elections are going on, and some assembly elections are going on. They are going to be the potential source of spreading. One has to be very careful with all precautions. This is where happening, and yes, it needs. It's not just the responsibility of the government, whether it is state or the central. So people should cooperate with the government for an effective implementation of what all the SOPs, all the precautionary measures. So government and public and private partnership is very important, and also a lot of private hospital also are cooperating. I mean, that's also another important thing. So definitely these are some of the drugs, particularly our own experience with steroid. It's excellent. Even remdesivir, although there is a flip-flop. Stories on this particular drug in our state. We had a meeting of pulmonologists, 7, 8 pulmonologists. They strongly feel if it is given at a right time to a right patient, definitely it is quite effective. So hopefully we'll look for a vaccine in the beginning of the new year. Whether this vaccine could be a new year gift, let us wait and watch. Thank you.
Thank you so much, sir. And you have actually given a complete scenario description of the whole ecosystem, how we are dealing and how we should deal with COVID-19. And the coming days are really very, very risky in terms, as you said, that Corona goes with the crowd. So, as we also got to know from Mr. Dr. Madan Gopal, and you also mentioned that a lot of work is being done in terms of prevention and test. You can say the testing and the screening, and a lot of things are done. But I can also see that in treatment, also country is doing really well. We can see good recovery rates. So while another wave is expected to come, how do you see Yeah, can you hear me? My internet just went. Am I audible?
Yeah, you are audible. Yeah.
I'm so sorry. Internet just there was some network issue. So I want to know from this panel on the side of treatment. So on like experience of yours with drugs like remdesivir. So if you just can elaborate more on that. if your personal experience in Karnataka.
Yeah. See, actually, we are our personal experience with the remdesivir in the state of Karnataka is quite satisfactory. And in our own hospital, Jaydev Institute of Cardiovascular Sciences, around just 300 people got infected, faculty and the people. Of them, nearly about 30 people were very sick. And of course, the combination of this thing was given. And of course, with God's grace, there is no mortality. Everybody recovered. Then, of course, we have a state expert committee on this therapy itself. So, which has got about 7 pulmonologists, renowned pulmonologists, who are actually dealing hundreds of cases daily. So, their experience is quite satisfactory, and they feel. I think this is one drug. If it is given, most important is the indication. One should understand. It should not be given to people who are very sick already on ventilator. That is then probably then I think it may not work. So before the massive before cytokine storm sets in, or before becoming extremely sick. So at moderate stage, if you catch patients in moderate stage, and that is the time if it is given, definitely the recovery is faster, and it reduces the hospitalization time also. And another interesting thing is it's quite cost effective also compared to what it was in June and July. Now it has come down, and not only this one, all consumables and all reagents are also started dropping. So our experience is quite satisfactory as well as this drug is concerned. And unfortunately, heparin, there is an acute shortage now. I was told the raw material was used to come from China. We have a problem with heparin. There are some 5-6 companies they are manufacturing, but they're not able to produce. Not able to supply heparin in there is a supply match demand. The supply is less and demand is more, particularly low molecular weight heparin. So we have some Gland Pharma or Biogen E and the other companies are there, but the demand is so much across the nation, they are not in a position. And also government of India has said, for next 6 months, if I am correct, the prices of heparin can be increased. That's what they have said. But in that order, they have said it's only for unfractionated heparin. But we want this low molecular weight heparin, because we want a free-filled system so that it is given to each patient and disposed of. Otherwise, that order need to be modified, in my opinion, because they are not able to supply heparin at a previous price, because there is a global shortage of raw material, global supply of heparin, because heparin is one thing which is an important and integral part of this COVID-19 management. Yeah, over.
Yes, I believe Karthik is facing some problems. So now I would like to request, taking clue from what Dr. C. Manjunath said about the shortage of the medicine. So I would request Mr. Naresh Hasija to please comment on this, because Mylan Pharmaceutical is one of the leading pharma organization in the world, and we would request you to comment on this, Mr. Hasija.
Thank you, Arshal. Would like to thanks the whole panel. Thank you very much for joining us here. And I think when pandemic started, our major responsibility was to make sure all the essential drugs are available in India. So for that, I think I will thanks our manufacturing team, R&D, as well as regulatory team who worked in tandem with each other in such a way so that none of our medicine remains short. So wherever we had state contracts, wherever we had supplies to federal government, we made sure our supplies are reaching there on time. It is we were dealing in serious infectious disease like HIV, viral hepatitis, biosimilars for oncology. We made sure these drugs are reaching to the users on time. As Dr. Manjunath rightly pointed out, see, normal care is getting affected because of COVID. But I will really say that we made our supplies during the month of March. We made our supplies during the month of April, and we really thank government also for allowing us to take some exceptions for the supplies, and I think we made it on time. Apart from that, introduction of remdesivir was also a fantastic example where whole technology transfer team, regulatory, manufacturing, everybody came together, and I think we made it on time. And you can see that I think initially itself, with introduction by 4 or 5 companies, we could save a lot of lives. We could impact a lot of lives in India. So we are very committed to make sure all essential drugs are reaching to public health as well as to the hospitals on time. Thank you.
Thank you. Thank you, Mr. Asija. And I think, and firstly, I'm sorry, some issue with the internet, so I got disconnected 2 times. And thank you, Harshil, for supporting in there in between. Rightly mentioned by Mr. Manjunath, a good experience with a drug which is dealing with COVID-19 in the country, and it's good news for every Indian. And a challenge of supply, as Mr. Naresh Asija mentioned, that yes, industry is actually working hard towards keeping a sufficient supply of drugs to fight with COVID-19. And now I would go to Mizoram, and there Dr. Pachao is here with us. Sir, you are the nodal in charge of COVID-19 task force in government of Mizoram. So I would like to ask you to share your experience, please, at the prevention side and also at the side of treatment with COVID-19. Please, doctor. You are on mute, Doctor Saab. Can you please unmute yourself?
Pardon?
Please. Mute earlier.
Yeah. Thank you. Good evening, all, and I'm glad that you give me this opportunity to highlight some of the preventive measures undertaken by the government of Mizoram as a whole, including the public people of the state. First of all, despite the rising number of cases and deaths all over the country, including northeastern states, Mizoram has not recorded any death so far. So today, the cumulative number of cases is 2,280 only. Well, we have 117 active cases. I'd like to start with the beginning of the operation. As soon as we have the news of the arrival of COVID-19, so we have instruction from government of India through the central IDSP. So use certain format produced by the central IDSP to carry forward to go for operation. First, we started with 28-day quarantine operation. So as we were having people, particularly students from China, not necessarily from Wuhan area, but from China as a whole. So as before they come to Mizoram, we created a sort of WhatsApp group with them. So we keep on communicating with them. So as soon as they arrive by flight in Mizoram, we started quarantining them for 28 days, which was the mandatory period. So towards the end of January, some other WhatsApp group were also created. Now we are glad to have a communication from Myanmar and Bangladesh also, including the neighboring Tripura state. So towards the end of January, our health minister, Dr. Arlal Thamina, convened a departmental meeting which comprised of different stakeholder departments, including home and other related departments. So we included in the meeting the NGOs and the church leaders. So everyone from each corner of the state would be participating in that. So in that meeting itself, COVID-19 task force at the state level was created. So after that, district level task force followed by village level or local level task force was created all over the state. So today, actually, we would like to thank the people who participated in the task force groups all over the state because they are the backbone of the operation. Uh, as soon as people started entering Mizoram, we screened them using this thermal screening. As well as we use we use a particular format which would be used for tracing them back once they just in case they contract the disease. So from our data, we can see that we got the first case which arrived from Netherlands in March on 24th, to be precise, on 24th March of the year. So April and May we didn't have a single case, but June brings 159 cases, and July 253, August 599, and in September we have the maximum number of cases totaling 1006. Today is 20th October. In October we have 262 cases, and the active case, as I mentioned today, is 117 only. And at the Zoram Medical College, which is a dedicated COVID hospital, we have a little bit of one serious COVID case with a ventilator. We use ventilator. Otherwise, most of the cases are not very serious. But lately, we think we started having a sort of a community transmission. So even last night, there were reports that some persons were complaining of some symptoms. So our teams would rush to their houses just before midnight and would collect samples and tested them by RAT antigen test. So today we tested. We got a little over 20 positive cases, which is quite comfortable, I'd say. So
Right.
like we have had the presentation earlier, is the committed government coordinated task force and ramp up infrastructure in terms of diagnostic facilities. You can see that our diagnostic facility, which is using RT-PCR, was finished, completed within a week with the able leadership of the minister. So public participation is amazing, and we also have some contact tracing teams from the police as well as in the health department. So we increase the capability of testing for the state. So from the preventive measures, I think we have done what we could do. And regarding the treatment,
Right.
we don't have so much of, complications from the patient, except from the imported case, I say, from Netherlands, who was in the hospital for over 40 days. But fortunately, he also recovered. We have dedicated teams in the hospital itself, which works on shifts. And the laboratory also, sometimes they work for almost 24 hours in shifts. So we are really fortunate to have dedicated teams, including our IDSP team and sample collection teams. And the government of Mizoram also went for, inviting volunteers from the public. So now we have over 900 volunteers working all over the
Great.
state who are in different capacities. So I think it's a sort of a comfortable level now, but we don't know what will happen since most of the cases are having symptoms these days. Thank you.
Right, doctor. I think you actually gave an insightful scenario of how it's going in Mizoram, and you also ended with a question that yes, still people are who are there facing symptoms. Mr. Hasija, before I move on to uh, Dr. K. Madan Gopal for a supplementary question, I would like to ask you. Can you comment on what Dr. Pachau has mentioned that yes, still there are symptoms in people. So, how treatment can be more better uh, uh, in these states?
So
Yeah,
I
you're
think we have been listening from clinicians about their experience.
yes,
We've been
yes,
listening different experiences from clinicians. I think they are the better judge for the right treatment in right situation. We just heard about Dr. Manjunath saying that if it is given it to right patient at right time, it matters the most. So I think we, as a pharmaceutical organization, we really fulfill our duty in making sure all these treatment options are available on time, and the mission which we are carrying as a global mission which we are carrying, we want to serve the 7 billion people. I think in these kind of public health crisis, our mission has become really strong right now, and we have gone all out to serve as much as we can. So I think this liberty of treatment is with the clinicians. Thank you.
right, right. That's a right point you have mentioned. I would like to ask Dr. K. Madan Gopal, sir, your PPT was really insightful, and we actually get a great idea of how Government of India is dealing with COVID-19. I would like to also ask you to throw some light on the treatment side. How now of this COVID-19 patients is going. We today there was a Oxford this research was there that we can also see the symptoms after some months in the COVID-19 recovered patient also. So throw some light on the treatment of the COVID-19 patients and the situation of the recovered patients. How government is looking at it.
One of the interesting questions is the treatment aspect. We have been constantly monitoring the outcomes of COVID patients, and based on that, we usually take a call. If you look at the outcomes, that means the how many of the closed cases they have recovered and how many are dead in that closed cases, not the actual case fatality rate. If you look at the closed cases, wherever there has been experimentation in the treatment, in the states which are doing a lot of experimentation, the mortality is very, very high. The outcomes are not very, very conducive for the general things. When this mortality thing came to us, so what we did, we have made an attempt to standardize the treatment protocol. There is a task force which handles this aspect, but we are very much aware that okay, there has to be standardized care. It's not the experimental drugs and other things they are having a role, but as that the inputs which I get from this discussion is that there is a shortage of low molecular heparin. That's very disturbing for me because that is the first line of drug, the first line of treatment for a serious patient because it's quite acute, manageable thromboembolic that kind of disease is there. If you want to fight that, that this is the drug which is to be available. Apart from that, regarding the treatment protocol, more or less as we are maturing. Initially, when we started, so there was reluctance on the part of others to use the hydrocortisone and other things. At that time, India had very less cases. 1,000 cases, 1.5 cases. But gaining from the as we are maturing, as we fortunately had a very late rise. As a result, we got matured and we have evolved our treatment protocols, and we more or less are managing the epidemic quite from the treatment point of view. But wherever experimentations have happened, if you look at the statistics and the data, initially everybody thought that it would be ventilator driven and everybody would be requiring ventilators. But if you look at the hospitalized patient, on a particular day, the patient on mechanical ventilators, invasive ventilator, is less than 0.3% of the hospitalized patient. If you go to any research, 0.3%. That means that modality is not there. The second is the supplements which are involved in this. Maximum patients are recovered on the supplements itself. Some require oxygenation. The oxygen requirement, if the saturation, that kind of as we are maturing, we are evolving, we are devising new methods. the SpO2 monitoring, pulse oximeter. So this, then we have now started monitoring the SpO2, and now anybody requiring this, apart from the other the antibiotics and the steroids, which are the discretion of the treating physician, the oxygen therapy has come into a mainstream treatment. In this way, we have evolved. It's not that there will be a perfect treatment. Regarding remdesivir and other experimental drugs, we still call experimental, whether it will only work when there is a replicating virus. And the decision has to be taken then and there only when to administer this drug based on the clinical condition of the patient. We can't be prescriptive, but a general broad consensus has evolved. And as a result, we are able to have one of the best outcomes in the world. If you look at the France and the European countries, if you compare the outcomes of European countries, even the US also, now they are improving the outcomes. But if you look at our outcomes, they are always been, now our outcomes is 98%. It's one of the best in the world outcomes. That is a closed cases. What is the outcome of the closed cases? Because our people, they have at least, if you follow, because the smaller the state, the better is the adherence to the protocol. If you look at Tamil Nadu, they have added to the protocol. Even the private and the government, they have added to the protocol. But if you come to the metros, where every hospital is, in fact, a deciding factor, and the mortality is very high in this metros. This is quite evident because it is visible. But wherever the states are following a strict protocol, that means these are the conditions. If you go to UP, they are having a protocol. This is the condition, this is the situation, you do this. This is the situation, you do this. But the titration of the treatment is entirely restaurant, but the guiding principles are there for the treatment. So treatment is more or less getting standardized and now coming up to a manageable limit. That's regarding
right.
being able to explain and give answer to your question. And
No, explain well.
Yes. One of the important aspects of any epidemic management is preventive deaths. We don't want deaths in an epidemic or any infection disease deaths. We don't. If you are able to prevent deaths because of standardization of care, because what in Delhi, if you look at the response, previously a lot of deaths were happening in Delhi, but after the intervention, what has happened? Audit has happened in all the hospitals regarding the treatments and other things. And slowly, everybody started adhering to a standardized pattern of care. So, as wealth of information is coming from this, we have to see that how we adopt that wealth of information, adopt the best practices, and see the things how. Low molecular heparin, that's a very disturbing thing which Dr. Manjunath has pointed out. I have just texted that thing to the relevant people that we have to at least watch the low molecular heparin. That's the input which I am getting from this panel discussion today. So thank you very much for that.
Okay, that's an honor, Dr. That and that is the purpose of this discussion, that important people connect to important people of all the areas in the country on this very important issue. So again, that is why I am having an industry expert here, and I connect. I want to discuss from both the sides. So that is why, like Mr. Hasija, you just heard Dr. Madan Gopal's views on treatment side and how to treat, what are the measures for treating COVID-19. So he is a policymaker side. So what do you expect from a policymaker, being an industry stakeholder, and how do you see to contribute? Like, as he said, that there should be some states who are actually following the protocols, going with the standards, guidelines, and there can be some states which are not so well going with that. Every hospital is deciding on their own. So in that situation, how do you expect a state government or a central government to from them, or how do you how would you like to contribute in this treatment process, Mr. Hasija?
Thank you, Karthik. I think first of all, let me thank Dr. Manjunath for raising this up. As Dr. Madan also said that this is news, but let me admit this here. We actually anticipated all raw materials which are coming from China. We anticipated there will be a small disruption which is going to come. We as an industry, I will say that, took right steps at that time. enoxaparin, it's like low molecular weight heparin. We also sell it in India. So we are one of the, I will say that, large players who take care of this across country. So in person, I think we assure Dr. Manjunath, we will make sure, uh, particularly the states which are using low molecular weight heparin will not have issue with the product. And through this, I would like to assure Dr. Madan Gopal also product will be available in enough quantities. So we have done some calculations, and I think we have worked with our partners in such a way that we will have the stocks coming in very soon. And I will only say that, sir, how it helps us is when you can, like, the same remdesivir also had faced the same problem. So it will be very, very helpful for us if the states can let us know with a better planning of next 2 to 3 months. Not only to us, it is to industry actually. Let us know what, so that we can also anticipate and procure. Now some of us have assumed the numbers where it is going to be, and we have procured some of the raw materials on time so that we can serve nation. And now we are anticipating this shortage is going to come. So I will say that it will be very, very helpful if you can help us in planning it better. If you can let us know these are going to be your requirements for next 2 3 months, I think we can perform better.
So we can discuss offline, no issues on that.
Sure, sir. Thank you.
Thank you, Mr. Asija. And it is great to hear from state, from center, and from industry. All the participants were there in this discussion, and some really informative and needful discussion being done. And now I will request for the final remarks, closing remarks from all three of you. And I will request for just to take a couple of minutes maximum in your remarks so that we can close on time, because we have already past 1 hour. So, Dr. Pachau, I will request you to quickly share your final remarks in the summary of this discussion.
A very
You're on mute.
enlightening session. Yeah. I think it's very, very enlightening session for me, myself, also including other participants across the country. And what is necessary for Mizoram now is more and more tests has to be conducted. But sometimes, in view of the community spread, which is coming up, we are not very sure whether we should go for mass testing or go for a particular containment area operation. Anyway, I think regarding the vaccine and the treatment, also our doctors have to be enlightened. So we would like to get more and more information from you, and also in terms of email or whatever electronic media, so that updated treatment protocol could be offered to us, because COVID is a novel virus. No one is actually specialized, I would say. So new things are coming up every day, including in our state also. So we would like to have more and more interactions with people across the country, particularly from the experts. Thank you.
Thank you, Doctor. Thank you so much. Dr. K. Madan Gopal, sir, I would like to request you for your final remarks.
Thank you. I will just mention Dr. Pachua that with AIMS media has been doing the grand challenges for the treatment protocols. That is available on the YouTube. I think offline I can send it to Karthik and he can share it with you, because I don't have your contact details. Another thing which I want to take this opportunity to mention is that though the number of cases has reduced to half, but the European countries, the Eastern Mediterranean countries, they have seen a second wave. The second rise is there. Apart from that, the outcomes in the northern states, which are experiencing temperature less than 25 degrees, the winter is setting there. They are also having outcomes are getting deranged there. So we have to ensure that our guard is not lowered, because today we have reached 45,000. We would be in a euphoria saying that from 97,000, we are having 45,000 per day. We should not be in a euphoria. We have to continue with the testing. You have to maintain and sustain the testing. Second thing, the non-pharmaceutical intervention till the vaccine comes. And hope so we will get a good news today evening when our Prime Minister would be addressing the nation. So what is the status and other thing. But nevertheless, we should see that the guard is not lowered. We should insist on non-pharmaceutical interventions like maintaining social distance, wearing a mask. If you would be surprised, everybody will appreciate that during the last 7, 8 months, I've been continuously working. Previously, in a year, I used to take a course of antibiotic at least twice in a year. But fortunately, by God grace, for the last 7, 8 months, no cetirizine, nothing. Even cetirizine, no paracetamol, no cetirizine, no antibiotic for the last 8 months. Because you are aware about your health. You just continue with that, wear mask, wash your hands, and you see that in Niti Aayog we have started the intervention as early as in March. None of my housekeeping staff till now they are reported positive, despite Delhi being the epicenter for the COVID cases. They have worked tirelessly and they are maintaining all these things. We have to set examples like that. The guard should not be lowered. We could experience second wave as experienced in this European countries and the Eastern Mediterranean countries. The second wave is coming. The northern part of the country, the outcomes are deteriorating. We have to keep our guard till safe vaccine is there and we are able to avoid this. That's the only message. Festivals are coming. You see the Kerala example. It all started around Onam, and now you can't do anything. That's leading every day 5% growth. Every day 5% growth is there. You can't say.
Yes.
Look the example of Goa also, where they have let go, and now the whole of the growth and other things. If you look at the best of the countries, if you take the per million case load in the states, it is more or less a par with the other countries which are experiencing this kind of daily surge. Okay, so having said that, only message is that we should see that the non-pharmaceutical interventions are in place. See that the infection is not brought from the community to the house. In the house, the elders are there. Maximum infection, majority infection happens people below 45 years of age. Maximum 80% infection. They bring the infection to the house, and the mortality data which is available, maximum deaths are happening in people above 50 years of age. 80% deaths. We have to see how this is very, very important thing. If you want to lose your seniors and other thing, then you lower the guard. Otherwise, don't lower the guard. Have mask, have social distancing, and hand washing. These are the three vaccines which are available now, right now, and they are very effective in preventing the other
True.
diseases which we have not talked about, even for tuberculosis, even for diarrhea, even for other non-communicable diseases. You see, Japan has been able to wait through the second wave because the non-pharmaceutical intervention, that is mask wearing, social distancing, they are already practicing. They have a good respiratory ethics there. The countries which are having all the three things already in place before the COVID, they have been able to manage the infection quite comfortably. These
Yes.
are my questions, and we see that how we adhere to that because you are having a lot of wider participant. I thought that the opportunity to share my concerns. So no need to lower the guard. Festivals are coming. Second waves the other countries are experiencing. We should not land there. Now we are better prepared, but we should not land in the second wave because of our foolishness. Okay, thank you from my side. Thank you very much.
Exactly. You've rightly pointed out these issues and how to save yourself and save the country and the mankind. Finally, Mr. Hasija, I would like to request you for your final remarks, please.
I think Dr. Madan Gopal has really taught us non-pharmaceutical way of handling this disease. And before even real vaccine comes, he has given us said, yes, your vaccine is in your hand. You can really take care of yourself. Not only yourself, more important is family as well as our elders at home. So from our industry perspective, I will only say that, see, we came in forefront of serving the nation. So our major preference was to work with public health. across India, as health is a state subject, we partnered with all the 26 states, and we were the preferred supplier of remdesivir to all these states. And whatever essential drugs they need, we would like to really, we treat this as like it's a public health crisis right now, and we wanted to come forward and serve the nation. We did our best, and I remember the times when there was a lockdown, and we were looking forward for how do we handle this lockdown situation digitally. So we augmented our digital supply chain, and it helped us a lot in that space. And we have people at the field who are working. The most important thing was to take care of our people at field as well as in factories, so that they can work day and night and really serve the nation. I will say that till now we could go very well in these situations, because discipline has imbibed in India. Now we can see that most of our professionals were really, really disciplined. With this, I will pause here and would like to thank everybody for their contribution. Thank you. A lot of learnings today. Thank you.
Thank you very much.
Definitely for me as well, great learning, and I thank and salute to you people also who are actually also COVID-19 warriors and helping the nation in fighting this COVID-19. Before wrapping up, I request for a 1-minute video. Please be here, and after that 1-minute video, we'll be wrapping up the session. So my team can play that video.
Is good enough? That's what we ask ourselves at Mylan. When we see dreams getting hindered by poor health, we feel good is not good enough. When possibilities can be accessed by just a few, good is not good enough. When health comes with a condition of affordability, we know good is not good enough. For more than half a century, we at Mylan have helped create better health around the world. We market more than 7,500 quality products that help people in more than 165 countries.
Because good health gets better only when it becomes more accessible to all. At Mylan, delivering better health for a better world isn't our job, it's our mission. Mylan, better health for a better world.
Thank you so much, and I hope that we all move on to a better health for a better world. Thank you everybody.